we want to talk today on posture, and these things all are coming directly from your text, so you can reference back to that as we go. There are a few things that I have added in for texture, and just so you can kind of see more to what it is that we're doing. But they should be really self-explanatory and very congruent to how the concepts play out. First of all, we want to start with the cervical spine, and I will tell you that this is not the only time we will do these specific exercises. They have other venues where we'll bring them in. But to start, we want to talk about improving axial extension. So what you're seeing here is typically this forward head posture, right? And so I don't have my screen. I should bring it up here for you, but you get the idea that most people kind of fall into this right here. Now that can be isolated to just the cervical spine. There's some other variables that could be playing in. Number one is they could have a disc pathology, and what we'll learn about at the onset of Therex 2 is people will either adopt a flexion or an extension bias, many times with spinal pain. And so what I'm saying is they may just have this going on right here because it hurts to extend, right? So think about the donut. And I know I keep going to the donut, and I'm sorry. There's just not a better analogy for this. But if they have a herniation, think the jelly or the cream has pushed out, right? Now, it's still encapsulated in the annulus, but it's found a new space that it shouldn't. Now, that impedes on the nerve root, and we'll see that again in Therex 2 when we start. But that nerve pain can be provoked by extension. Another thing that can provoke pain from extension, or extension can provoke pain in, is when there's a facet joint dysfunction. And again, this is a Therex 2 thing, but just hang with me for a minute. You know that the facets in the cervical spine have a very vertical orientation, very much like this right here. But that's what allows for flexion and extension to occur. Well, the facets, when they are disrupted, and we'll learn more about this again, there's a piece of soft tissue there, kind of like a disc, kind of like a meniscus, that will get folded into those facet joints. And so their extension will hurt. How many of you have had a crick in your neck? And so the next time that it happens, and you know it happens kind of like idiopathically. You just wake up and you're like, oh, my neck hurts, right? Probably did a little bit too much relaxing. The pillow was just right. It let some things happen where this moved and that moved, and then the disc moved, and just got trapped. And you wake up the next morning and you're like, ah. And so now you're walking like this. You're like, hey, Ryan, right? Instead of turning your head, because that's what hurts, but also extension hurts. So in the cases of those two specific things, you don't do these. Why? Because pain is provoked by extension, right? Now, that's a long way around just to tell you this. When it's a postural issue, when they walk in, you see the forward head. What do you want to do? First things first, let's look at head nodding. Many times, if it's a postural fault, remember that's a very benign thing that once we kind of get them moving, they get out of it. Do some head nodding. Why is head nodding effective? Because it's very subtle and it's very easy and people get it, right? So it's a really low level exercise. So let's all sit up on our ischial tubes and let's do some gentle head nodding. And this all comes from, real quick, well, this is not in this chapter actually, this is in the next chapter down, but I'll direct you to that page here in just a minute. But we're going to start from a very good postured position, ischial tubes, and we're going chin to chest, and then back up to neutral. Chin to chest. Don't ask me how many reps, just do 1 million. Okay? Reps are arbitrary at this point. Right? And so, here's another thing. I'm going to walk over here. Aaron, you continue to do the exercise for me. Now let's look as Aaron gently head nods. We're seeing an eccentric component of the extensors and then a concentric component of the extensors. An eccentric component and a concentric component. Are you following the words that I'm saying right there? Let me bring Lindsay in because she's not seeing this. Keep going. Do you see the eccentric component and the concentric component? Those extensors, right? And so typically speaking, these muscles are going to be weak. Are they going to have a stretch weakness or are they going to have a tight weakness? What do you suppose? Monica, hit it.
Which ones? Wait, you asked that again?
She's stalling. Okay, so we have the cervical extensors, right? And we're seeing a forward head posture. All we're doing is the gentle head nodding. Eccentric, concentric. Join with me there. Put your hand right here on your clavicles. Right? Now, let your head come down and touch your hand. And back up. Everybody, as they're on down, eccentric.
Eccentric.
Everybody up, say concentric.
Concentric.
Now again, eccentric, concentric, eccentric, concentric, eccentric. Now think about it. Use your brain and connect it to those muscles. You feel the eccentrics of that, right? It's lowering it down. It's decelerating. That's exactly the definition we want you to walk away from with eccentric, right? So what are we doing? We're improving many times either a stretch weakness or a tight weakness. On the posterior aspect, many times it is a stretch weakness. These muscles are elongated and they're weak. So we're going to strengthen them. Now, if it's a postural fault, it's a pretty simple head nod and done. There's another, though, that we may want to bring into the picture, and that is chin tucks. Now, chin tucks are extremely potent when it comes to improving deep segmental activation. So think about the picture of the coli, of the capitis muscles, all those little bitty muscles, right? Now, what we want to do is we want to start with 2 fingers. So find yourself your peace fingers, put your peace fingers together, put those little dudes on your chin, and now I want you to pretend like you're a turtle. And right now you're outside of your shell, and I want you to go back in, but not all the way. Good, Aaron's really got it down now. Outside of the shell, and inside. Oh, this is a good one to do. Alright, everybody doing some chin tucks. Right? Now again, I said this is an extremely potent exercise for deep segmental activation. It is the drawing in maneuver of the cervical spine.
So you're saying potent as in good? Good.
Very good.
I always thought potent is bad. Like potent smell.
Potent strong.
Yeah, strong. Oh, strong. Okay.
Yeah.
Alright.
Here we go. You ready for this?
Mm-hmm.
I'm secretly trying to employ a strategy over to a person who was talking to me about nutrition earlier. We won't say the name. I believe that fasting and carbohydrate restriction are extremely potent in weight loss.
Okay. Good for it.
It's positive.
Okay. But if it's a potent smell, it's bad.
It's a strong.
I don't know.
Oh, strong. Okay.
Could be a bad
I
smell.
don't
So
know.
they're synonyms.
I've told you that I have the nose of Wolverine. And so there are sometimes, and it's very specific, like there are some fruity perfumes that, man, I adore them. There are some flowery perfumes that, like, girl walks in down the hall wearing this certain perfume and I'm like, I'm gonna go throw up and have a migraine. Like, it's bad.
I've lost a lot of smell.
What's that?
I've lost a lot of smell since I've had Corona.
I'm sorry.
Alright, she made buffalo chicken the other day, could not smell it.
That's not a bad.
I didn't know of any buffalo chicken that was around here.
It was a microwavable meal. I didn't actually make it.
No.
You know,
But Dakari said it smelled good.
Yeah, it did smell
And
good.
Aaron said it didn't
I
smell
don't smell
I'm sorry. I am. I have a friend who, he still can't taste the most.
I
I've
He
seen
was
a lot
gone. I'm sorry, that really is pretty awful. All right, so we got the chin tucks, we got the head nod. Can you instruct a patient on how to do those? Because guess what? This is the first thing that you do in your skills check. Right here. First thing. Next on the list is scapular retraction. Now, again, everybody get in your good posture on your ischial tube. Listen, posture starts at the pelvis. I don't know why that's not in on your slides. Like, it's probably the worst omission I'll make in this module. Posture starts at the pelvis. Pelvis means ischial tubes. Get on. Like, that's where you start, right? Now, for you guys that are standing, now with that, it starts at the pelvis. You know where else it's got something to do with? I want you to tie a string to your head and pull it. Nice! Everybody's doing good. Okay? Now from that, your string broke?
Yeah.
Okay, so with your string on top of your head, you pulled yourself up. Yes, ma'am.
Oh no.
Oh, you were holding your string. Gotcha, sorry. Okay. Thought you had a question. You're holding your string. Alright, so from your good position here, from your improved active position, here's what I want you to do. I want you to pretend that your BFF is holding a quarter, like the coin, between your scapula. And they're going to let it go, and I want you to keep it there, right? So we're going to activate our rhomboids. Squeeze them.
You go back as far as you can, or you just.
Till it won't go back no further.
There's me to stand up straight like that.
Right?
Hard to do.
Now, this is a lot, right? In fact, here in a few minutes, we're going to talk about pelvic tilts, right? And so there's the posterior pelvic tilt, which flattens the lordotic spine, or the lumbar spine, sorry. There's the anterior pelvic tilt, which increases lordosis of the lumbar spine. Well, where is the middle? Well, this is not middle. Like, you shouldn't walk around like this. If you're holding your rhomboids contracted, it's kind of like, you know, when you see those guys at the gym, and they're like. Right. Now they often don't have tight rhomboids. They have stretched rhomboids because they walk around like this. Right, and their shoulders are way forward. They're protracted. Big tight, pec major, pec minor's tight, those kind of things like we talked about. So, this is the activation of it though, right? So that's the simple first step, is just scapular retraction and then protract for me. Retract and protract. Now, let's name that. Let's make that easy. What are those called? Those are called shoulder rolls, aren't they? Right? Let's really get our brains tied into our scapula, shall we? Everybody knows what the clock does? Clockwise, 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 clockwise. All right. Let's use our right scapula. Just our right scapula. And here's what I'd like for you to do. Retract it. Elevate it. Protract it. Depress it. Retract it. Elevate it. Protract it. Depress it. Pretty cool, huh? And if you can do that continually with no load, then why don't you load it in plantigrade? Retraction, elevation, protraction, depression, retraction, elevation, protraction, depression. I'm trying to change my depression there. Alright? Think about the muscles that do that. How are you getting them engaged, right? Very small, subtle stuff. That could be like the deep segmental activation around the scapula. So we have that. And then we also need to bring in this one. And everybody's going to stand up for this one and give yourself some space. Because the social distancing around that table over there is probably just, you know, going to get in your way. Sorry, I'm picking on you. All right. So there's a series of exercises that many times we associate with scapular retraction. So that means you scapularly retract. So get your retraction on. Everybody got your retraction on? Now, the A's, which is where we start, think about you've got a TheraBand out in front of you and the two pieces are suspended down to your hands, okay? And in fact, we will do this. So I retract and then I bring in my limb movements. Do you remember this morning when we talked about limb movements?
No.
And we said proximal stability for distal control. All right? So we're bringing in the proximal stability right here out of the scapula. The scapula cannot be left in the car. We got to bring it in the house with us. So there's the scapula. Brought it in with the rhomboids. Then what are we doing? We're bringing in limb movement. You see it? And this is called different. When in Rome, do as Romans. If they don't call this an A and they call it an I, call it an I. I don't care. I call this an I right here. Right? Some people call this an I. I like to call it an A because it looks more like an A. You just do whatever they do. Okay? Now, T's a little bit, it's a little bit more consistent, right? This is a T. Retract. Now look, movement is not much because we're retracted the whole time. Ooh, are you feeling that? Rosie's not feeling it. She's just over there going, this is too easy, Kendall.
We did all these in my clinic, actually. We used like all of them on everybody. It seemed like.
Because posture re-education is probably necessary. Let's get our Y's going. This is where Kendall's going to be awful. In fact, if you can't see it, let me turn. Do you notice anything about my left range of motion versus my right? Just from here, as I retract, my left sucks. So I'm going to try to catch up with it. Oi! Hold that retraction. Subtle movements, right? What's the matter?
Burning.
You need to go to the gym. Okay. Hey, I've been there. All right, so everybody come up this way. Now, that was a great active range of motion. Let's load it. We load first with gravity. You ready? Would you bring Lindsay in? Thank you very much. Here's how we can start loading with gravity. Hang on, I gotta get one thing. Sorry. What do we call this? What do we call this?
Bolster.
Head.
It's probably covered in COVID. and I'm gonna put my face right on it. Woo! This is what I'm willing to do for you guys. This is called a prone pillow, and I'm yelling so that you guys can hear me. You got the prone pillow part?
Mm-hmm.
Okay. This is called Cobra. Here. Prone pillow. Here I go. Scapular retract against gravity. Scapular retraction. Eyes. T's. What?
Don't hold your breath.
I'm holding my breath. Okay. One of the tools that we can use. Now, does a person have to use that? Listen, if they have enough stabilization, bring that head off the end of the table. Now you're really asking some cervical retraction, aren't you? Rosie's a little worried. Come try.
I ain't trying to do that.
You got it.
You ain't trying because you ain't trying. Try. You don't know what you don't know.
We actually did these on a Theraval.
You did them on a Theraval.
And they had cuff weights. And they did like hockey weights.
They had cuff weights.
You ain't gotta add that though.
You shouldn't have said anything.
And you did it on Theraval.
Uh-oh.
You saw it from around here.
Lord, Rose.
They aren't this heavy.
Those are twos, aren't they?
Yeah, these are three.
You got it?
Yeah, sure I do.
You got it.
I'm never making a face again.
She's never making a face?
Again.
I didn't think you made a face. I can't see your face anyway.
Okay, so we did like.
You're wearing a face mask.
Eyes, and then teeth, and then
Hang on, time out. Show us the eyes again. What are your eyes?
Our eyes are this. Not
Our eyes are this.
This was ours. We didn't do the down.
Our eyes are this.
T and then Y's. I think she did A's, but that was with the stick.
Well, I got a stick.
No, it was a different exercise, like totally different. No, they were laying supine. It was different. But we did it on this, and against so it's a good.
I just need to see the A's with the stick now. Don't hit me.
This.
My goodness.
Literally, this is it.
Just standing there with a stick?
No, they were laying
That's
down.
boring.
They
Huh?
were laying down. A, then I, then T, and then Y. We did it like, I guess, 3 different ways.
How'd you get a Chick-fil-A mask? That's crazy. You gotta be a
Did you
gold
donate?
member or a red member? That's nuts.
Some poor staff was taking the trash out.
Yeah. Chicken member.
That's a cool mask.
That's so cool.
So that right there, that's a great prone technique. We could take, and I apologize, I know you probably don't realize this. Many times what we do is we take the door and we close it to do a lot of our TheraBand work. And so that's why I'm referencing that way. You could take the TheraBand and they could do these activities that way with the TheraBand. I also have on there though, that you could do this
Standing.
supine. And so I really wanted to give you just a minute to see that one as well. Because do you mind taking our now? So from a supine position, now this one is going to be a little bit different, right? Because at this level, we need to consider, okay, so we had these muscles on the posterior chain that are weak. Were they stretch weak or were they tight weak? They were stretch weak. Now, let's talk about how to do these muscles that are tight weak. Right? Same thing. I's, T's, Y's, A's, whatever. Here's my eyes. However, one of the things that I want to get to and get you to understand is that you strengthen the tight weakness in a lengthened position. You don't want to feed this more, right? What am I saying there? Don't make these more tight by strengthening them in this position, right? So we're not doing this. You know, we retract and train there.
So does that mean you don't go through the whole range of motion?
That, and you lengthen as you go. Now, there's a couple of ways to do this. Sorry, I'm all over the place. The way to avoid my disruptions in my talk today would have been if I would have been prepared and acquired all these cool tools ahead of time. Whew. Be careful. Oh, be careful.
Oh, Kendall, you're scanning.
Look at this retraction I just got passively. Wonderful. Now take a look at my pec major and pec minor. Are they lengthened? They sure are. Right? Very passive way of doing it. Now, is this uncomfortable? Oh my gosh. Like, the end of this roller is so shoved into my suboccipital space, and I'm telling you, I'm about to pass out. Somebody catch me if I do. But here, I'm also engaging some really unique aspects of balance that are not normally engaged. Okay? So here I am, got my eyes.
Oh gosh.
This is where Rosie's cuff weights would be really handy. Bring in my T's. But take a look. It's strengthening from a lengthening position. Test question. How do you strengthen a tight weakness? Strengthen from a lengthened position. Right? Take a look. Here's my T's. Woo! I like this. Man, I'm getting some crazy feedback right now. Hang on, let me show you my Y's. Oh, look at that left shoulder. Extension sucks. Got it? Ooh, careful. Lindsay's probably amused. So, I showed you standing, I showed you prone, I showed you supine. What is the big difference there? For prone, we're working on the stretch weakness muscles of the posterior chain. For supine, we're working on the tight weakness muscles for the anterior chain from a lengthened position, right? Strengthen from a lengthened position. On a tight weakness, not a stretch weakness. Questions?
Yeah.
Doesn't that soothe your ADHD? It does mine so well. I have a TheraBand on my chair in the office and I just bounce it all the time. Around the legs on your chair. Around the bottom. Bounce. Super soothing. All right, so let's review. Everybody do some head nods. Start from the, where does posture start? From the pelvis. Everybody that's sitting. Sorry, Noah, you're out on this. Let's get us some head nods, gentle head nods. Eccentric, concentric, eccentric, concentric, eccentric, concentric. Now, peace fingers, put them together on your chin. Chin tuck, be a turtle. Hey, let me go ahead and modify this right now. We're going to do this in Therex 2. Let's do it now. Man, I'm building up my repertoire. Listen, if chin tucks hurt to do them from neutral, that means your eyeballs are level. Here's what I want you to do. I want you to flex the cervical spine. Why don't you try that for me? Now, what does that do? Huh? Modify a little bit more. Alright, so pretend that my dorsum of my hand is the posterior aspect of the spine. Pretend, okay? Using lots of words. Dorsum. You guys get that one? You love that word. Alright, so we flex, right? And what that does is that opens up the posterior aspect of the vertebrae. It's really, really nasty because what I'm going to say the whole time is when you flex, you push the jelly out the back, right? We've said that about 9 million times. However, when the jelly's already pushed out the back, it hurts if you go neutral or extend. So they have a flexion bias. We have mentioned that one. We'll get more into that at their too. So they kind of like lumbar spine or cervical spine, either one. That's where you're going to have disc problems that are at least symptomatic. You can have thoracic disc issues, but they're largely asymptomatic. So here's what they do. The lumbar spine specifically is they'll come in and they'll be like, oh, my back's hurting. And look at the gait pattern. Oh my, let's just go ahead and review. They're flexed, their hips are flexed, their knees are flexed, they're short stepped, right? You're like, bam, I got that from gait. They walk in like this. And you're like, hey, got a disc problem. And you're like, yeah. You're like, can you climb up here and get in prone? And they're like, nope. They want nothing to do with it. And so you're like, no, but I really need you on my traction table. And they're like, ain't doing it. And you're like, but the book says, and Kendall says, that if you get into traction, it'll separate those vertebral segments and that disc will fall back in. And if you use gravity by putting them in prone, it's going to work even better. And they're like, not doing it. But then you say, well, you're in a flexed bias. I'll put you supine in a position called hook line, right? And some of you cheaply stuck that stool underneath some feet and legs. That was awful, by the way.
What?
Not remembering who for sure put me on that traction table with stool underneath my legs.
Oh, we did.
Oh,
Mm-hmm.
that's how
Yeah, that's
fast
what
I
I
that's
thought.
what we're going.
Maybe a pillow between the legs and the stool would
Where's
be
the
nice.
pillow? Where's the pillow?
Oh, the comfort feature.
Oh, we don't have pillows. I did that, didn't I? Again, I didn't want people getting coronavirus from sharing pillows. Okay, so just let's close the loop on that. Let's think about it. How else can we do it? Right? That's the only reason why you stick them on their back. Otherwise, the best way, put them prone, let gravity do its job. Rabbit trailing, sorry. Scapular retraction, we got that. Standing, A's, I's, T's, Y's, prone, supine, pelvic tilt time. All right, how do you teach a pelvic tilt? How many of you know what a pelvic tilt is?
Thought you didn't part of that
Tuck your tail.
when you
Oh.
had to do the weird move.
I don't know, come tell me.
Cat.
Share it with me, what you got?
Do what?
Huh? You tell us, you got some thoughts.
I think that was the one that, I'm not for sure, I'm not certain, but I think that's the one that you was showing me and Shelby, and we were on all fours, and it was like you just had to arch your back a whole lot, and then you had to roll. Was that?
It does get, yes, and I would argue
Yeah.
possibly the very best way to do it is through cat camel first, because gravity is really good in that.
Yeah, that's what you call it.
However, that's on the next one. That's called the total spine movement, and that's where we're gonna leave that. So, are you sitting on your ischial tubes? Adam is sitting on the exercise ball. This is a great place to start because the ball really facilitates that movement. Now, put in your mind this concept. Just think about the pelvis. That is the ischial bones down to the ischial tuberosity, right? So your ASIS, your PSIS, all the way down. That is the complex known as the pelvis, right? And that dude, when the bottom, everybody know where the pubic symphysis is? If you don't, raise your hand. Nobody's gonna
Can
own
you
that
show me
one.
where it is?
Yes, sir. Thank you, Dakari, for being an honest soul.
I didn't wanna take that one.
Isn't that the little thing between?
Look, I have to push from the center of the map. Right there. Come touch it. Okay. That is the pubic symphysis. This is the pelvis right here. If the pubic symphysis goes up and forward, this is terrible. If it goes up and forward, is it anterior or posterior? Pelvic tilt.
Posterior.
Posterior. It's posterior.
We said it.
I know it. It's terrible. They just did
So
this.
it's just always in reverse.
Well, let's not say always. That gets pretty bad
When
too.
it says that, it's
Why don't
in
you just say
reverse.
that the direction of the iliac crest is the direction
That's
of the tilt?
exactly right.
Okay.
So that's exactly right. You start from the iliac crest here. If it goes that way, that's a posterior pelvic tilt. But the movement many times is initiated from right here. Now, Noah likes to do deadlifts. He does. And if he does a deadlift correctly, wait, hang on, I jumped ahead of myself just a little bit. What muscles do you suppose make this pelvis go like that? You watching? It's that.
Iliopsoas.
You like the psoas? Let's just try this together. Posterior pelvic tilt. Iliacus? Could they?
Yeah. No.
I wouldn't argue that they couldn't. How about this? Noah's over there. He's about to do some deadlift. So he's going to assume this deadlift position. We're just going to pretend this is what you do. Okay? Right? And he's about to pick up the bar. He's going to initiate that by getting his hamstrings to posterior pelvic tilt. Oh my, we just changed the world. Can you do it? Get your hamstrings to posterior pelvic tilt. But wait a second, they only hip extension and knee flexion, Kendall. You've got this all wrong. Get them. Come on, give me a try. I love it. Ooh, what are you doing? I don't see any pelvic tilts out of your hamstrings yet. Got to get in your starting position. Oh, come on, I still did. Did you see it? I didn't see it. Everybody look at Noah's pubic symphysis. Get in your position. We're all staring at your pubic symphysis. Don't feel awkward.
Roll your butt under.
He's going too fast.
Slow it down.
I like what you like a meme. Did you feel it?
Do you want to touch it?
Do you ever think you initiate the deadlift by doing a pelvic tilt out of your hamstring? Next time, think about it. So the pelvic tilt right there. The iliac crest goes posterior. Now let's do an anterior pelvic tilt. Right? Now, as you're sitting, you're in the optimal position to teach pelvic tilts. I have seen very many times students attempt to teach pelvic tilts from hook line. Well, let's just go through why that's not a good idea. All right? We know what a posterior pelvic tilt and an anterior pelvic tilt look like, right?
Yeah.
You know what I got going on here? I got a block behind my pelvis. And we're like, hey, I want you to do this thing called a pelvic tilt. And they think they're creative because they're like, I'm going to put my hand in the lumbar spine area and I want you to squish it. And it sounds good in theory. The problem is there's not enough going on up here to get that connection anyways. So do not teach pelvic tilts from a hook line supine position. Guess what you get to do in your skills check? Teach pelvic tilts. Guess what you're not going to do in your skills check? Teach them from this position right here. Okay? Now, you see that? Posterior pelvic tilt. Anterior pelvic tilt. Can I do them? Heck yeah, I can. However, it's just not preferred. Let's get into our good ischial tube posture, right? And when you do that, you should be at neutral spine. Neutral spine is that happy place between an anterior pelvic tilt and a posterior pelvic tilt. A neutral spine is what we're going to tell you later in Therex 2. This is where you want to lift from. So when Noah does deadlift, when Noah does bench press, although there's an argument probably ready to be made, he needs a neutral spine to do it in. Because the neutral spine is ready to accept this thing called intra-abdominal pressure. Oh, we talked about that this morning, right? Not a Valsalva, but a very acceptable pressure that is managed. How do you manage it?
By exhaling on exertion.
Exhale on effort, right? So you have to control that exhale. And here's what we're going to tell you. Exhaling is very much a passive act, right? These sacs called the lungs that are not muscles, they inhale air because of the diaphragm, and then when you exhale, or is it active at all? No, it's a negative pressure out. However, I'm going to blow your mind here. Is it actually eccentric by the diaphragm? Forced. So that would be concentric. Oh, now we've got something to go home and think about. As if you didn't have enough. Okay, so we've got this neutral spine. The easiest way to posterior pelvic tilt is to literally fall back on your sacrum. Right? Now, your patients, they don't get that. So what you do is sometimes you have to tactile cue, putting your hands on their ASIS. Oh, that got Noah's attention real fast. I told you to put your hands on their ASIS, Noah. And then we're going to go into an anterior pelvic tilt. That means the iliac crest goes forward, right? Okay, so push that out. That also means they get a big lumbar lordosis. Take them back to neutral, mid-ground. They should be fitting or feeling their ischial tubes in contact with their seat. Go back to a posterior pelvic tilt. Up to neutral. Expand to an anterior pelvic tilt. Oh. Now, that's one of the first ways to teach those tilts. Now, there's some more. First of all, from a seated position, can you do a hip hike? Kind of tough, isn't it? Is that a lateral pelvic tilt? Oh, it is. A lateral pelvic tilt. Is lateral pelvic tilt necessary in gait? Absolutely. And if it's excessive, one might say that there might be a muscle weakness in the glute medius called a... Rosie, I gotta get you a microphone. Trendelenburg.
I didn't hear an I was right here. That's great.
Oh, terrible. She talks into that mask and I'm like that one day she talked and I was like, did someone just
Nobody
say
knew
something?
her.
It's when she was sick. So she started
over there anyway, and I was like,
man,
Yeah.
I think it scared Carol like that.
Well, I was like,
it scared me, man. I was like, ooh, that's kind of freaky, man. Okay, so now we're sitting here all kind of wag the tail, get loosened back up here, get your neutral spine. How about a little rotational pelvic tilt? Okay, so what does that mean? That means the right side goes forward, the left side goes back. You go back to neutral, the left side goes forward, the right side goes back. Woo. And those of you who are sitting on round stools are like, I am a pro. Okay. Are they necessary for gait? Yes, they are. How many degrees is average, normal gait, pelvic rotation? Say 8. Because it's 4 plus 4, right? I know, you guys are right. I was just giving you a time. How about toe out? You got that one?
7.
Okay. Man, you guys are rocking and rolling. All right. Next on our list. So there's our pelvic tilts. It's important for you to speak and be able to teach them. All right. Here's the bad news. Just like passive range of motion and everything else we've ever done, you, the student, know how to do it. You're not going to be great at this when it comes time to actually teach someone who doesn't know how to do it. So be patient when you're trying to talk these things out. Now, there's another way, and that is the total spinal movement, and that is what we're going to next. From a seated position, though, it involves, again, this is where it starts, at the pelvis, right? The total spinal movement, though, in your book, it describes this, and I want to give you a page number so you can go reference it later. It describes this on page 431, and this is what it looks like. It begins with being in a posterior pelvic tilt, so there's sacral sitting, and let's go ahead and add in cervical flexion. So what you're going to do is you're going to try to kyphosis the entire spine. Right? That's a big statement. Sorry, I had to make it. So let's all get into this right here. Now, bonus question for the day. What ligament is most being stretched in the spine from this position? Rosie gets 1 million points.
I see you heard her.
The question is, did Shelby even know what you said? Maybe you should say it with your smoker voice.
I don't have that no more though.
Well, you're not sure.
Well, there's longitudinal ligament.
Okay? Now, here's what we do. First, we're going to move from a posterior pelvic tilt, take them into an anterior pelvic tilt, lumbar lordosis, thoracic extension, cervical extension. Alright? So that is, did you read this? Did you catch it? Total spinal movement. Yes, ma'am.
Can you do that again? I got confused in the
Sure.
beginning.
Let's start back from our sacral posterior pelvic tilt, right? Posterior pelvic tilt, thoracic kyphosis. Your lumbar spine should be curved in a kyphosis way, and your cervical spine should be flexed. So you're sitting on your sacrum, your lumbar spine is flexed, your thoracic spine is flexed, and your cervical spine is flexed. You are as flexed as you can get, right? Now, we're going to activate the posterior chain. First at the pelvis, which means you're going to move from a posterior pelvic tilt into an anterior pelvic tilt. Your lumbar spine is going to extend. Your thoracic spine is going to extend, and you're going to retract your scapulae into cervical extension. Now, is that a great little exercise to do? Yes. But sometimes our patients don't quite get it. Here is your workaround, and it is known as the cat camel, right? And it's a quadruped position to do the total spinal movement. Now, to do this, what we want to first start with is a 90-degree angle hip, and then your arms are at 90 degrees as well. Right? What is this known as? Quadruped, right? So you start from quadruped. The yoga people will call this tabletop, right here. And what we're going to do is we're going to start from cat position. Now, I really want to pull my my posterior pelvic tilt in. So pretend there's a string on your pubic symphysis, and your forehead. And the string just got shorter. Oh, stretch that out. Now you're going to lengthen that string. First, you're going to begin to drop your lumbar spine down, which means you're going to enter your pelvic tilt. You're going to lift your head just like so. And now I'm in a total spinal movement. Right? And I would repeat that. What we will tell you is that as you become more proficient with those, what you can do is you can rock backwards and lose some of that 90-degree angle. Actually, you increase the angle of your hip flexion and do them as well. And that changes where you will feel that in your lumbar spine. Okay? So we're going to try those as well. Next on my list is what we did in class, and that's thoracic spine mobilization with diaphragmatic breathing. That is standing on a wall, hips back, heels back, hips back, scapulae and head, right? And instead of, well, let me ask you, how did you cue people to diaphragmatically breathe in rehab? What did you tell them? What did you learn how to tell them?
Touch your hands.
Okay. What position were they in? Were they seated, lying?
Seated.
Okay. Which is, by the way, the best way to start. Now, there's another thing that I need to tell you about diaphragmatic breathing, and it may not be the place to tell you, but I'm going to tell you. You will read in some resources that sitting is the best way to teach them. However, the most advantageous way to diaphragmatically breathe is in a forward lean position, like this right here.
Same for the TA drawing in exercise to go in
The
that feedback.
TA they like for quadruped.
I just meant like the gravity, it gives them
Yes,
feedback.
sorry, yes. Okay, throwing a lot at you today, sorry. The stuff you need to know is on the paper though. So, diaphragmatic breathing, is it for inspiration or expiration? Inspiration, it is the muscle of inspiration, right? The lungs, they're just sacs. So, do it like this, think about them like balloons. When you air up a balloon, right? And then when you take your fingers off the end of the balloon just deflates. That's what the lungs do. It's a negative pressure. So everybody up on your ischial tubes, right? Flag it loose if you need to. Okay, so I'm breathing in through my nose, which is an incredibly lost art. At least it is for me. Some of you may be great nose breathers. I'm not. Okay? But when you go to the wall and you put yourself on the wall, you're going to feel something different. Dakota, you are one of the members on the wall this morning. What did you feel?
Pressure right here.
Yeah, and you feel, because your back is up against the wall, you'll feel the, watch this word, extension of the ribs as they come forward, okay? The word extension, by the way, literally means opening. Flexion is closing of a joint, and so that may help you to process why that's named extension. Next on our list, cervical stretching techniques. All right, to do this, you're going to want to reference page 432. And it will identify how to do the suboccipital region, the levator scapulae, and the scalenes. But you know what? I think it's going to be fun here. How about somebody in here show us how to stretch suboccipital muscles? Now, put the pieces together. Don't be reading it. Don't be reading it. Stephanie's trying to cheat.
No, I'm trying to write it down. I didn't get the page numbers.
432. How do you, there you go. Do it again, Rosie. Now think about this. You hear the word suboccipital. Process that down and say, okay, that means muscles that are right here, suboccipital, right? Medical terminology tells us that. And then, by the way, I'm going to stretch them, which means I'm going to lengthen them. So, stretch your suboccipital muscles again. Good. Now, just take a look at Rosie. She's not maintaining that stretch for 30 seconds for some reason. Low load, long duration. That's a big key thing from stretching. Do you remember that? Aaron does. I know Aaron does because he was like talking about it just the other day. We had a long conversation. The levator scapula is a little bit different. What does the levator scapula do? It elevates the scapula. Levator, elevator, right? So that. So here's how we're going to stretch that. Your text says depress the scapula and cervical flexion and rotation to the opposite side. So look, I'm going to do everything I can to stretch that dude by depressing, rotating, and side flexing. Oh man, I love stretching this muscle. Now, that is if it's indicated. If it's indicated. Sometimes that muscle's already stretched out. Then we got our scalenes, and to do those, we need axial extension and side bend of the neck opposite the side of irritation. So here's our scalenes. So we extend and side bend at the same time. And then you're getting those scalene muscles. You know, while we're stretching those muscles out, let's talk about this real quick. What's that major structure that likes to slide through those scalenes before it goes into the supraclavicular fossa? The brachial plexus. Oh, yes. And if the scalenes happen to be too tight, that can cause a condition called thoracic outlet syndrome, right? But don't fear, we're going to talk about that one in third. Okay, next on our list, let's talk about muscles, specifically of the, how did I word that? Upper thoracic stretching. Okay, so upper thoracic. So I'm going to bring in really muscles of the ribs. So what muscles do we want to talk about stretching? Let's first start with our pec minor, because it's easy. Everybody knows how to do this one. Interlace your fingers, put them behind your head. Now I want you to pretend like there's a string tied to the front of your elbows and you're going to break it. This is a great pec minor stretch. And by the way, while you're doing this, you're working your retractors, getting a little bit of posterior delta in there, which is historically a bad muscle to ever get strong. Right? Now let's go over and let's talk about how to do the pec major. Everybody come on. Remember, we're doing thoracic muscles, right? Here's my pec major stretch of reference. Oh, we're bringing Lindsay. Okay, here we go. Stretch the pec major. Alright? Now, here's what you can't ask me. How long do you hold that stretch, Kendall?
1,000,000 years.
Low load, long duration. What's optimal from the stretch chapter?
30 seconds, Alex? No?
Depends on their age.
30 seconds.
30 seconds is optimal.
A minute for older
60
people.
if they're well elderly. What does that mean? That means you decrease the load, increase the duration. Oh, you're seeing it all come together and you're like, Kendall, I know. I'm good. I got this. And I'm like, I know you do. Next on our list, we have to think about this and when you are stretching the thoracic aspect, you really want to be trying to promote thoracic extension. Okay, and so I have written on, or I have in the book, that it also does the latissimus dorsi, and that's a really unique stretch. But think about the latissimus dorsi as it comes from the posterior rib cage over, right? What it wants to do is it wants to get tight there. And so to stretch that, how do we do it? What's it say there, Stephanie? Tell them what's the first thing they would do on the latissimus dorsi right there.
Oh.
She has to read upside down. Give her some
Self-stretch, lying supine on a foam roll, reach arms overhead.
Okay. Lying supine on a foam roller. Remember how I was? Arms overhead. That's a really simple way to do it. Another really quick way, if you don't want to put somebody on that roller, which by the way, it's probably not appropriate to do that with every patient, right? But we could always do something like this right here and achieve similar results. Okay? But what does that do? Take a look deeper. In fact, Noah, would you assume that position for me? Noah's worried we're going to look at his pubic symphysis again.
Oh my goodness.
Okay? This is causing thoracic extension. That's the key to the whole thing. What did you do to get thoracic extension? All right? So, come back over here. I showed you this a minute ago. Let me bring it back into play. We're going to do everything we can to get our patients into extension. All right? Here's extension. This is called a Sphinx pose. If you don't know why, go home and look up a Sphinx. Here is a Cobra pose. But take a look at my thoracic spine. Right? Do you see the extension that this is causing to happen? That's a big one. And do you see how that helps to offset the kyphosis that could occur in the thoracic spine? Questions on that? We're rolling.
When I explained that to a patient, she didn't really know what
We're
a pose was,
an
so I
hour.
just said, have you ever watched The Little Mermaid when she's on the rock? I love
My
that.
favorite scene.
And she knew it just right then. So, it's creativity.
Listen, I love it. Do what you need to do to make things happen.
I see I said that you're gonna have to find ways, like 1,000 ways to explain the same movement. You just have to relate to the person in some way.
And not to mention the repetition of every time they come in, you're going to repeat it.
Yeah.
Like the one that I find so often, which my only patient right now is my father-in-law, but every time we're in here, I have to repeat on hip hikes, don't bend your knee. Because here's his hip hike when we start. And I'm like, no. Your knee is straight, your hip is pulling it up. He's like, oh yeah. And I'm like, how do you start doing that again when you've got 3 in? That's on record. Lumbar and hip stretches. All right, so again, we're looking at muscles that are tight. Now, let me ask you. We do a whole lot of this right here. What muscles do you think are tight?
Oh,
Well, you're right.
okay.
The rectus, that's okay. Hip flexors. And the knee flexors. So how does one stretch those two types? I could put them prone again, right? Here comes the Cobra, here comes the Sphinx. That gets the hip flexors. Now, if it's up to me, I would love to see a patient do this right here. Really get that iliopsoas and that rectus femoris. However, not a lot of patients are ready for that. Especially if you were to try to put them in to this right here, right? I mean, let's talk about kneeling and how challenging a half kneeling position is anyways on balance. So you gotta get creative. You tell them to get here in prone and they're like, Because most older people, they're gonna tell you, they haven't been on their belly in years. What are you gonna do? Get creative. How are you gonna get those hip flexors stretched? Anybody do this?
Yeah.
In their skills check? Hmm? How about those hamstrings? How you gonna stretch them? Stretch a prone hamstring? Come show me.
No, I didn't say that.
You did say that. That happened. Like, your mic was on and I heard it.
I said out loud today.
That everybody in the class heard, and we're waiting to see a prone hamstring stretch.
Like,
Hang on.
and then dangle the leg.
Nope, I'm not even willing to try. What?
Like prone and dangle the leg. I don't know. No, I'm good.
Rosie, thank you for being a willing participant jumping in there. Right. We can leave them supine, but remember, this is just as simple as this right here, right? That's a hamstring stretch. Right? So you can do that passively. But again, what are we doing? We're stretching the knee flexors. It's a big one. Another one though is how do we stretch the hip extensors like the glute max? You got any thoughts on that one?
I'm not saying nothing else.
You had it.
I don't like it. Single knee to chest, double knee to chest. Really like single knee to chest better than double knee to chest. It seems like when you do double knee to chest, it's like whether they have, oh well, that's too deep. So here's single knee to chest, right? And don't give me any grief. I know my knee's not on my chest. But what is that stretching? Primarily at the glutes, but it also really gets the QLs. And you really find a lot of improvement in mobility to the erector spinae. So QLs are kind of more lateral, erector spinae are a little more medial or axial.
Is axial and medial synonymous?
I would say, yeah. I was indicating it that way,
Okay.
yeah. Oh, this is interesting. Okay. So we're good on that one, right? And then finally, let's talk about how to do a posture analysis. Stephanie, you're so good. Would you bring Lindsay with you?
Yeah.
All right, so everybody come over. Now you're a really academic group. You like to know questions, you have curiosity. I love that about you. I love some of the questions that you guys bring, especially when I don't know the answer, because it really helps me. There's not just like a tried and true way to set somebody up on this. In fact, it's largely like, how do you get the perception started, right? So can I use you for this one? All right, so I'm just gonna bring Ryan over here and I'm gonna say, Ryan, I just want you to stand on this side right here of the line. Now the line is stationary. We're not gonna move that a lot, right? Because it's just there. So just come stand on the other side of the line. Try not to bump it so that it stays really still. Okay? And so when he gets into that line, I just want you to stand still. What I'm gonna do now is I'm gonna move. Right? And some of us in here have a knowledge of this too, that we have a dominant eye, right? Like, I know my right eye is my dominant eye. My son and my wife are left eye dominant, And so when they shoot a gun, instead of being here, they're here. And I'm like, still, that's just wearing me smooth out. But that's what they do. And I want them to shoot guns, so I just encourage it. But I'm gonna look and I'm gonna try to find that line. My goodness, you're swaying a lot. Oh, that's what balance people do in balance, don't they? Look at that. And I'm gonna try to, the way I do this is I connect the earlobe first. The book will tell you earlobe. It will also mention the external meatus.
Meatus.
The meatus. Yes, thank you. As the location, it's the ear. Okay, just start at the ear. And I'll put it on the earlobe, and then I will see where it lands. Now, for him, at the earlobe, and then as we go down, his shoulders are a little back, but not too bad. It does transect through his lumbar bodies, greater trochanter. It is posterior to the patella and just anterior to the knee, so he's doing pretty good, right? All right, so come on and very gently come out so you don't bump the line. Every time they bump the line, it swings, and then it becomes a pendulum as opposed to a plumb bob. Here's where this is effective. Earl and Linda got pillows alike. That was my posture.
Great.
Right?
You're doing great.
So what do you do with this? Why is this important? How does this work? Snap a picture. The cell phone has revolutionized this. You take a picture and you say, listen, here's some visual feedback, right? You bring the mirror in. That's why we have the mirror, so people can see. Or if they just kind of stand and they're like, my shoulders are level. And you're like, no, they're not. Stand up straight. And you stand up and they're like, oh, this is not right. Right? You give them feedback. They look at the symmetrograph. They look at this and you say, this is what we're trying to accomplish. And then they understand that that visual feedback transcends into the treatment. Then they see why the chin tucks are important, why the thoracic extension is important, why having a neutral spine as opposed to a sway back or a flat back posture is important, right? And so they get buy-in, and that's really probably the critical point of doing posture analysis is screen, rescreen, or rather screen, treat, rescreen. So, there's your lab.